Chest pain is one of the most common reasons why patients come to the hospital. But guess what? Most chest pain is not due to heart attack. But missing the one that is can cost a life. Today I'm going to talk to you about how we approach chest pain in the ED or in the hospital and how we use high sensitivity troponin to our advantage. And this is based on the recent guidelines from the American College of Cardiology. The first thing that you need to look for in a patient who presents with chest pain is rule out life-threatening conditions. Life-threatening conditions that can cause chest pain are not a lot. These are either acute coronary syndrome, acute pulmonary embolism, aortic dissection, tension pneumothorax, or esophageal rupture. Make sure that the patient is not having any of these life-threatening conditions. All right. And then in your approach, you need to do, the first thing that you need to do is a 12-lead EKG, especially within the first 10 minutes of arrival. This is because you don't want to rule out ST elevation myocardial infarction because it's very time sensitive. In fact, here in the United States, when a patient complains of chest pain and calls the emergency medical services, then they will do the EKG in the field at the side of the scene and transmit it to the hospital where it can be read. And if the patient has a STEMI, the cath lab will be ready for him. So the next thing is to do a focus history and physical exam, and then you assess if the patient is hemodynamically stable or not. And if the EKG shows STEMI, don't worry about ordering any other labs or tests or anything. Just activate the cath lab, take the patient to the cath lab and get the angiogram done. So if there is no ST elevation myocardial infarction on the EKG, then you are still suspecting possibility of acute coronary syndrome because you don't have any other obvious reasons for the chest pain. Then you need to get your high sensitivity troponin. So this is the 0-hour high sensitivity troponin interpretation. We all know that high sensitivity troponins are very sensitive. They detect even the smallest amounts of troponin elevation in the blood compared to the older regular sensitivity troponins. And the change in the troponin levels occur much faster with high sensitivity troponins. So previously with the regular sensitivity troponin, we followed the troponin maybe every minimum like 3 hours, maximum up to 6 hours, right, to see the change. But with high sensitivity troponin, you can do that within 1 hour or 2 hours after the first test. So based on the first high sensitivity troponin level, you can actually do some risk stratification. So if the 0-hour high sensitivity troponin level is below the limit of detection for the assay, there are different assays that assess high sensitivity troponin, and they have different levels of detection. So if it's below the limit of detection for that assay, and the patient presented at least after 3 hours of symptom onset, then this patient had a very low probability of myocardial infarction with a 30-day major adverse cardiovascular event of less than 1%. This patient can be discharged from the ED. The next one is if the patient has a detectable but less than 99th percentile of a high sensitivity troponin, these patients you need to repeat second high sensitivity troponin before you can say anything in terms of the risk for acute coronary syndrome. Patient had an elevated, or it's like a higher than 99th percentile troponin, high sensitivity troponin, in these patients myocardial injury is present because the troponin is elevated, and this could be from myocardial infarction or myocardial injury from any other cause, but these patients are high risk and you need to bring in these patients for further workup. All right. The repeat testing can be done at 1 or 2 hours according to the institutional protocol. The maximum is up to 3 hours, but most patients come to the hospital usually like maybe after 2 hours of their chest pain. It's very unlikely that a patient with chest pain will come to the ED in 30 minutes or an hour. Therefore, so you repeat the high sensitivity troponin at 1 or 2 hours after the first one. And you are more interested in the absolute change in the troponin level than the relative increase. When we were using the regular sensitivity troponins, we said significant elevation or change in troponin is if there is a 20% or more increment of the troponin after 3 to 6 hours. But here with the high sensitivity troponin, rather than the relative increase, is the absolute value. And each assay has different levels for the 1 hour or 2 hour delta to be considered as significant. So we don't have a specific number. Some use maybe an absolute change less than 3 is non-significant, 3 to 5 is intermediate, and above 5 is significant. Now, we're talking about nanograms per liter here, but you have to check with your own assay. So significant rise and fall will suggest acute myocardial infarction. Therefore, the disposition guide based on these two sequential high sensitivity troponin testing is if the patient is considered low risk if the high sensitivity troponin is very low from the get-go, or the serial value remains less than the 99th percentile and the delta is not significant for that assay, and the patient has non-ischemic EKG. These patients are very low risk. They can be discharged with early follow-up. Intermediate risk. These patients are patients with detectable troponin above the limit of detection but still less than the 99th percentile, and the delta is also not very low and not high. It's equivocal, indeterminate. These patients are considered intermediate risk, and these patients need to be observed in the hospital with a third troponin level, a repeat EKG, and based on that, they might need a stress testing or a coronary CT angiogram. High-risk patients are those patients with high sensitivity troponin above the 99th percentile, or there is significant delta at 1 hour or 2 hour, or those patients with ischemic EKG change. These patients are considered high risk. These patients have myocardial injury, which could be from myocardial infarction, and these patients need to be admitted and managed with further workup. So a couple of clinical pearls here. Troponin elevation does not always equal myocardial infarction. It could be myocardial injury as well, which is non-ischemic. Always integrate the symptoms, the EKG pictures, and the trend in the troponin before making the decisions. Or if you're using a regular sensitivity troponin, make sure that you also use some sort of a pathway, clinical diagnostic pathway like the heart score to help you risk stratify these patients, and always apply the assay specific cutoffs for the high sensitivity troponins per your institutional lab standards. There is no single number that we use for a significant delta or an abnormal troponin level. It's different for the different labs.